Thank you very much for the kind introduction, and delighted to have the opportunity to talk to prospective medical students and biomedical science students that might want to come to Oxford. What I was going to do in the next 45 minutes is just give you a little bit of an overview of what is physiology and some of my research and some work that's not even published yet. So you guys are seeing it for the first time. But also I wanted to maybe give a couple of vignettes on if you come to Oxford to read medicine or biomedical science. So I'm going to give you a little bit of a lecture that our two hosts have already experienced, because I teach medical students and BMS students in years 1, 2, and 3. So as you can see from my title, Cardiac Neurobiology, and as was just mentioned, I kind of gravitate between two organ systems, the brain and the heart. And this is a subspecialty in medicine called Cardiac Neurobiology, where neurology and cardiovascular medicine meet. So if I can get my slides to go forward, it's just... Let me just try one more time. Emma, can you see the slides okay?
I can see the slides, yeah, but they're not moving.
Yeah, okay, let me just see if I can get this to go. What I might do is just stop sharing and start again, if that's okay.
Yeah, of course.
Okay, how's that one? Yeah, okay, we're good to go. Right, this is the foibles of doing Teams and PowerPoint, because we're back live with students now. Don't do this so much. Okay, so one of the key things are like, what is physiology? Because at school, you won't be doing physiology that you know about. You'll be doing biology for most of you, wanting to do medicine or biomedical sciences. So you've got to do chemistry, obviously, but most of you will be doing biology. And physiology is a big subset of biology. So what we're really concerned about is the study of function of the human body. So mechanistic understanding about how we locomote, how we breathe, the visual system, how we remember things, how we reproduce. And importantly, physiology is very closely coupled to anatomy. So anatomy is all about structure. Structure and function go together. And if you want to be a good physician or a good surgeon, you need to understand about structure. And in the slide here, you'll see a cartoon of the brain. Don't worry too much about the detail of the anatomy here, but basically you've got subspecialized structures here. And the reason I'm showing you this is the importance of this structure to function has really come to pass now, and especially in neurosurgery. So with the advent of CT scanning and MRI, you can get very good 3D representation of neural structures down to millimeter resolution. And the reason this is important is that if you're a neurosurgeon and you're sticking electrodes deep into the brain to treat various disorders, such as movement disorders or idiopathic pain that doesn't respond to conventional pharmacology, you've got to know exactly where you're going. So some of you hopefully might be able to see the little blue dot here where the laser pointer is. And this is a part of the brain deep into the midbrain. This is called the aqueduct here. And this particular neuroanatomical structure has got a technical name called the periaqueductal ductal gray. It's just a complicated word. You'll forget it in a second. But I just want to, give you exactly what I'd say to the medical students. And this part of the brain is really important because it integrates information about pain. So pain information coming from the periphery, this is the part of the brain that integrates that information. And if you have a patient with neuropathic pain who doesn't respond to classical pharmacological interventions, then surgeons can come into this part of the brain and they can inactivate overactive circuits here. And we call this deep brain stimulation. So here we have the situation, and you can see what I'm highlighting here now is that the brain and all the way down to the spinal cord has very good connectivity to end organs, whether it's the heart, the kidney, and the blood vessels. And on the other side, it also receives information. We call this sensory information or feedback information. And this information modulates the overall activity of the neural patterning that goes to the end organ. Now, if we return to our patient who's had a brain implant here, and this is done under functional neurosurgery here, and this is a study that one of my former students did, who's now professor of neurosurgery at Oxford. And what he found when he went into patients into this part of the brain called the PAG, then when he activated certain neurons, he could take the blood pressure down. When he activated different types of neurons in the structure, he could take the blood pressure up. And we published this almost 20 years ago now that you can see. And we thought at the time this is really exciting because we had identified midbrain targets that could modulate the cardiovascular system, even though the patients at the time were being treated for untreatable pain. When we mentioned this to one of the device companies called Medtronic, who do all of the advanced material work for pacemakers, etc., they thought, yeah, this is really interesting, but no one's going to have their blood pressure treated by having a hole drilled in their head. Let's just stick to the main pharmacology. So wind on almost 25 years. If you look at what Elon Musk is now doing, he has got microsensors in the brain in patients that are remotely controlling specific types of neural firing. So this is not such a far-fetched idea for doing treatment. And I think in your working time, you will actually see this in operation clinically.
Are you speaking with the hands?
So this just kind of summarizes just what I've been talking about. So here's your brain here, and here are the autonomic outflow tracts. And you may be recall that you may have done this in A-level biology, that the parasympathetic nervous system and the sympathetic nervous system are the two main parts of the autonomic nervous system. The parasympathetic is kind of like the brake on the system, rest and digest. Sympathetic system causes excitation. And you've got sensory information coming from the periphery with specialized cells located around the body that feed back to modulate what is going on here. So one of the key concepts that we talk about in the first year to medical students is the concept of integration. And this comes in two forms. One form is horizontal integration. And what I mean by that is that we're still in the same spatial scale, but we're interested in the communication across organ systems that give rise to complex behavior. And one of the most complex things that you'll do in life is to exercise. And in order to exercise successfully in a homeostatic way, it's really important that you coordinate all body function. And that's brought about by these communication systems. So when you want the muscles to contract, you need to send an impulse down to the muscle for it to generate force. But importantly, the muscle needs blood. And that blood must come from somewhere. And when you're at rest, most of your cardiac output is in the non-exercising vascular tissue. We call this the viscera. So this is the intestine, the stomach, the liver, and the kidney. When you start to exercise, that blood has to get to the muscle. And in order for that to happen, you've got to vasoconstrict down the non-exercising vascular beds. And of course, you need to activate the heart to get the output up, and you need to breathe harder. And nature has developed a system whereby you can do all of these things. So blood flow control is really interesting because you're probably taught at school that, yes, you need to dilate the muscle because you need to get oxygen to the muscle and remove carbon dioxide. That's all true. But often what is missed is one of the main physiological reasons that you dilate is that you must control muscle temperature, because if you never dilated, the muscle would cook. and all the enzyme systems would then denature. So heat loss is a very important component of homeostatic control. The other form of integration is what we call vertical integration. So this is taking information from the very reductive part of us all the way through spatially to making us as one person. So we have about 20,000 genes that encode about 60,000 proteins, 200 different cell types, 4 tissue types, 12 organs, which make up us. And what is really important is to understand how this process takes place. So in the first year at Oxford as a medical student or a biomedical science student, you spend a lot in the reductive domain, understanding how genes encode proteins, understanding about transcriptomics, metabolomics, and proteomics, and how proteins interact to form kind of complex structure. Because a lot of disease resides at this level of spatial domain. The horizontal level of integration is a part of the course that you mainly see in the second year. So like this is beautifully applied to this particular problem here. So COVID-19 is a very interesting disease because it's a disease of multiple organ systems. And this is really where physiology, neuroscience, and immunology meet. And when you study at Oxford, you get to learn about all 3 of those particular disciplines. So we know the SARS-CoV-2 virus is aerosol driven. It comes into the lungs. And of course, you probably know quite a lot about this now, just given the media over the last few years. But the spike protein binds to what's called an ACE2 receptor. This translocates the virus into the cell. And then the coronavirus hijacks the internal transcriptional machinery of the cell and starts to make copy of the virus. And what the body wants to do is to get that virus out of the system. And one of its responses is to have an immune response to that. And often what tends to happen when people get really sick with COVID-19 is that their immune system goes into overdrive and you get an overcompensation and a multiple inflammatory response that takes place, because this particular virus doesn't just hit the respiratory apparatus, it also targets other organs directly because of the spike protein on to the ACE2 receptor. And as the body is trying to clear this virus, you get this over-inflammatory based response. And sadly, people that don't make it through COVID die of multiple organ failure. That is, they hypoperfuse because they're so vasodilated, very similar to septic shock, and the tissue gets underperfused or hypoxic. So understanding how these systems communicate is very important in becoming a doctor. Now, in physiology, it's not like chemistry or physics. In chemistry and physics are really our parent subject, because chemistry and physics, they have a lot of laws. Physiology and biology have very, very few laws, although physiology is critically important because remember, it's the Nobel Prize in physiology or medicine. So we have 4 key principles that you will come across as a student, but you'll also remember these principles as a doctor too. So we have, my slides sadly have just stopped again. Let's see if I can get them going. Here we go. So we have the concept of homeostasis, that is optimal set point control, keeping temperature at 37 degrees, pH at 7.4, blood gases within the normal range, blood pressure roughly 120 over 80 if you're a man, 110 over 70 millimeters of mercury if you're a woman. This is really important for body function. Adaptation, that is the ability of the body to adapt to an external stimulus. So if you go running and become athletically fit, then you'll get the phenotype of an athlete. If you spend all your days in McDonald's eating hamburgers, you'll adapt to the hamburger and become obese and get metabolic syndrome. So you will adapt to that stimulus, but eventually a pathology will arrive. We also have the concept of redundancy. That is, there's more than one way to control a system for homeostasis. And if this system is really important and critical for your life, you have multiple ways, a little bit like multiple computers that you might see on the space shuttle, for example. And finally, we have the concept of feedback. And feedback can be negative feedback because this is really important for homeostatic control, but feedback can also be positive. And in biological systems, you don't get that many positive feedback systems. They're mainly seen in physical systems. Where you do see positive feedback is during disease, pathophysiology. And in order to break the cycle of positive feedback, you need an intervention, which might be a medicine or it might be a surgeon fixing the problem. That is, you need to break the vicious cycle of positivity. Now, one of the things that I've been interested in for about 20 years is this connectivity between the nervous system and end organ function, especially the targeting to the myocardium, which we call neurocardiology. And because of improved computation and improved imaging, we've been able to get very good detailed information about how the nervous system gets to these organs. We kind of call this the internet superhighway. And as a consequence, we're building the virtual human in 3 dimensions. And this project is actually bigger than the Genome Project. It's very international. And you will get to use this as doctors and scientists during your working lifetime, where you can tap on organ systems and you can zoom right down to the level of the protein. You could put in mutations and you can look at how the body functions in terms of simulation. And this will be important to help guide personalized therapy. So let's come back to the heart again. And you may have seen a picture like this in A2 biology. So if you slice the heart in half, you pick up certain anatomical structures, and you know that the nerve impulse propagates down the pacemaking system, through the conducting system, all the way down to the ventricle. Electrical activity always precedes contraction. And of course, the doctor is picking up the ECG on the patient's torso. So this is the electrical wave escaping the heart. And you will learn at Oxford in the first 2 terms about the biophysical properties that underpin the shape of these action potentials. I'll just pull out one salient feature. This sharp bit here, we call this the QRS complex. This is ventricular depolarization. So it correlates with the upstroke of the action potential here. And as the cell repolarizes back to normal, then this would be represented on the torso of the patient by the T wave. So the QRS is the upstroke and repolarization would be the T wave. And cardiologists can get a diagnostic description of electrical abnormalities by looking at the electrical signature on the patient. Now, zooming down in terms of vertical integration now, this one slide illustrates a whole term's worth of work summarized in one slide, which is kind of unique as a first-year student at Oxford. And I'll just explain it. It's quite simple, really. It might look complicated, but it's really simple. That when you want the heart to contract, you need an electrical event to take place. So this is this action potential here. This is called depolarization. You activate voltage-gated sodium channels. Sodium comes into the cell. But as you start getting depolarization, you move into the voltage and activation range of sodium, so it eventually turns off. And then you move into the voltage activation of calcium channels. So calcium channels now open on the T-tubular membrane here, and calcium rushes into the cell. It then triggers the activation of more calcium to be released from internal stores, in this case, the cytoplasmic reticulum. And then that calcium binds onto contractile proteins like troponin C. So you may have done sliding filament theory for muscle contraction. So what is taking place here is that the tropomyosin complex is inhibitory at rest, so it'll rotate off the thin filament, the actin, allowing the active binding site of the myosin head to form a cross bridge. And that is the actual power stroke for contraction to take place. But equally important, the heart must relax. And the heart needs to relax because it needs filling time. And for that to happen, the calcium levels must come down. So the inhibitory action of the tropomyosin complex can reform, and then the contraction comes down. But the calcium comes down because there are active transport systems to pump the calcium out of the cell back to where it came from, and also to hide it in microdomains in structures like mitochondria. And you could also exchange the calcium too. This is really important. If you don't get this right, then you will have a cardiac arrest. So you have a number of ways of maintaining calcium homeostasis. And if you lose one of the key proteins, you've got a redundant control system here. So coming back to the coupling circuit now. So here is the heart, here is the wiring that goes into the heart. Now, of course, the heart at rest has its own intrinsic rhythm, but because of receptors that sit on heart cells, we call these G protein coupled receptors, they are linked to adrenergic system, that is the sympathetic system, and the muscarinic system, which the parasympathetic nervous system innervates into. So there's a tight neurochemical junction between the nervous system and the heart itself. And why we're interested in this, for a number of years, a number of groups, including mine in Oxford, have noticed that as primary cardiovascular disease progresses, this also causes a neural remodeling that takes place. So although hypertension and heart failure are cardiovascular diseases, you also get impairment of the autonomic nervous system, which gives rise to driving some of the etiology of the pathology. And we're particularly interested in this early switch from the healthy state to what we call the pre-disease state. That is, if we can understand more about this for targeting, then hopefully we can develop therapies before patients get overt clinical signs of the disease. Because once they've got the disease out here, it's getting harder to treat it. So we're trying to get on top of the early window here. Okay, so let's move into some more contemporary work. So this is the brain-heart connection, and it's a simple cartoon. And there are a number of patients in the wider community that have diseases of these ion channels that affect the shape of the action potential here. And these are called cardiac channelopathies. And the prevalence of these is around 1 in 5,000 to 1 in 10,000 people. So if you've got a population of 65 million people, like the UK, you can figure out that there's quite a few of these people around. So these mutations you're born with, but if they're not treated, they can become very dangerous and become a precursor to serious arrhythmia and even sudden cardiac death. And interestingly, they're facilitated or precipitated by things like psychological stress or physical activity. And of course, psychological stress and physical activity is where you get activation of the sympathetic nervous system when you want to go for a run. And often, sadly, we see in some young people that episodes of arrhythmia and sudden death, that is, you may have seen this with in the newspaper of sports people, dropping dead while playing football, etc. Typically on post-mortem, they are found to have a structural abnormality, and they may have one of these channelopathies. So one of the most dominant ones is a mutation in a potassium channel that gives rise to what's called long QT syndrome. And this is quite easy to diagnose because the QT interval on the ECG is very long, which is reflected by a long action potential duration. There's another one, which is a gain of function mutation that sits inside the heart cell itself, where the cytoplasmic reticulum is. And this one tends to dump out too much calcium. and that can cause arrhythmia. And it's called CPVT, and I'm going to tell you a little bit more about that in a moment. It's a catecholamine polymorphic ventricular tachycardia. So it's really activated by the sympathetic nervous system. So here is our target, and here is our modulator. That is either the sympathetics or the parasympathetics. Now, interestingly, in disease, primary cardiovascular disease, this is the accelerator. This is out of control, and the parasympathetic is your natural brake to the system, and that's broken. And that's very hard to target because of the fast movement of transmitters. So most of the therapy is really directed at this neural axis here, predominantly at the level of the heart with drugs like beta blockers, etc. So neuromodulation therapy, this is really getting more tractability in clinical medicine now, especially in the United States and certain parts of Europe, not so much in the United Kingdom, because this is quite expensive to do this. And what I mean by neuromodulation therapy, again, it comes back to this notion of organ-to-organ communication. So for example, if you've got hypertension, then there's some pretty good evidence now, if you denervate the kidney, then you can take down the sympathetic transmission and reduce blood pressure. So you're getting less vasoconstriction on blood vessels. If you activate the parasympathetic nervous system, and you can do this non-invasively with what we call tragus nerve stimulation, that works pretty well. There's some good groups in the United States doing that. But one of the big targets is this ganglia here, which is one of the main ganglia innervating the heart, where the sympathetic nervous system goes through. And one of the current big therapies here is to really chop this out. So again, this is popular in the United States, where patients undergo stylectomy here, where the circuit is taken out. Beta blockers, one of the big problems is they have a lot of off-target action in the system. And one of the side effects of beta blockers, especially in young people, is they get very fatigued. So their compliance for the drugs are quite low. So one popular intervention in Italy and in California, and also Johns Hopkins Medical School, is for patients to have surgical intervention where they are stylectomized. So in the cartoon here, what the vascular surgeon is doing is undertaking a unilateral stylectomy or a bilateral stylectomy. And I'll just show you a little bit of the data. So what you have here is patients over time for 12 months. And what's been recorded is ventricular tachycardia and implantable defibrillator shocks in the patient. So these are patients that are really vulnerable for sudden death. So they've got an implantable defibrillator. And if you've been bilaterally stylectomized, you can see that their mortality statistics are way better than if you've been unilaterally stylectomized. So if you're bilaterally stylectomized, you do pretty well. If you had no implantable defibrillator in here, then the risk is that these patients will have sudden death and die. So these are patients that have been pre-screened and are highly vulnerable for sudden cardiac death, often given a family history of premature death within the family itself. So around the world, we have a very big program called bioelectronic medicine for neurocardiology. So this is basic research where that type of animal research meets clinical research as we test various interventions for optimization for new therapeutics going through. And this is quite a large consortium. I happen to be the European lead in Oxford, and our main partner is in California at University of California, Los Angeles, with other partners at Johns Hopkins and Northwestern University, and our European partner is the University of Bordeaux. And this work is gathering momentum at the moment. Where we currently are in patients in Oxford at the John Radcliffe Hospital, the neurosurgeons quite often implant Rather than going into the brain, they can go into the spinal cord and implant small stimulators. And this is treating patients that have got pain, and we get really good pain relief in these patients. But the nice thing is, if we measure their blood pressure and their sympathetic neural traffic, we can take all of that down. So this is in many ways a multimodal therapy, albeit it's there to treat pain, but we also see very good control of neurogenic hypertension. And surprise, surprise, often patients that have pain also have high blood pressure too, because it's one of the signs of pain itself. One of the other modalities for treating patients in terms of targeting the nervous system and the heart, in addition to electroceutics, which I've just talked about, is cell therapy and gene therapy. And again, this is basic science which is evolving. So the classic therapy is down at the level of the heart. So this is where beta blockers come, or calcium channel antagonists may be given here. But the paradigm shift that although the problem is in the heart, the trigger of the event is another cell upstream. And by simple analogy, the bomb is the heart, but the fuse is the neuron. So I mentioned that you might cut the fuse or cut the neuron or sympathectomize the patient. I should say that if you completely remove the neuron, that is also not without its own side effects, because to do this, you need to have a very good vascular surgeon who only gets the cardiac branch of the stellate ganglia. The stellate also has got innervation into the face, and there is a risk of patients developing Horner's syndrome, which means that they'll get sort of droopy eyelids and lose facial muscle control. And often that is a cosmetic side effect that young people are not prepared to take. So younger people tend not to want to have the stellectomy because of the potential side effect. So what we're trying to do for them is, rather than take the nerve out, we're trying to turn down the gain of the nerve, a bit like the volume switch. If we can take down the excitability, then we can minimize excessive transmission, which leads to all the downstream problems that take place. Now, I'll just show you one example of how we do this. So I'm coming back to this mutation again, CPVT. This is the catecholaminergic polymorphic ventricular tachycardia. This is quite hard to diagnose in patients because their ECG is normal at rest and their hearts are structurally normal. But if you carry the mutation, it's just when they exercise or get stressed, then you see this really ugly looking electrical signature on their ECG. And carriers of this, again, a prevalence about 1 in 5,000 to 10,000 people of Western ancestry, we know that. But it's got a very, very high mortality rate, almost 50% in untreated patients under the age of 40. So it is a big, big problem. So one of the things that we've been trying to do is to develop model systems, because this is very hard to recapitulate in a mouse or a rat. So one of the things that we've been doing is to really target the human disease in a dish. And the way we've been able to recapitulate the actual neurocircuitry here is to use a stem cell approach. And what I mean by that is that we're able to take skin cells from patients with a known genotype and phenotype. And with these patients, what we can do, we can differentiate their cells back into an immature state, into their pluripotent state, and we can make any other cell type that we want. And obviously the two cell types that we're interested in are neurons and myocytes themselves. And hopefully this might come up. Yeah, unfortunately, it's not wanting to advance itself. But anyway, the concept here is that we can, in monoculture, have a heart cell and we can have a neuron, and then we can put the two cells together in co-culture. And if we do that, we can actually study the communication between these two cells. The most important thing, I think, is the new finding, is that this particular model system is contextualized to human. That is, it's very personalized. It's not a mouse or a rat or a guinea pig. It's from a patient that has got the known disease. So here we can study the heart cell by itself, we can study the neuron by itself, and then we can put the two together. And I'll just show you one bit of data. And what this bit of data shows you is that we find that as well as abnormal signaling in the heart cell, we have seen for the first time that this is also a disease of the neuron too, in terms of abnormal calcium regulation. Calcium is really important because it's the final messenger that underpins exocytosis or neurosecretion. And if this is not controlled properly, then you get too much chemical transmission taking place. So, understanding about this wiring, I think, presents a really big opportunity. My lab and my colleagues, we're just focused on the heart, but you could also apply the same principles to the kidney, to the stomach, to the intestine, and to the pulmonary system also. And really being able to tap into this and take individual patient genomes and work this up in a very controlled manner, I think gives a new opportunity for target discovery, for new medicines going forward in terms of understanding where the dysregulation takes place. If we can understand the full transcriptional machinery within the cells and the exact bits which are diseased, we can develop medicines to target and restore that. So this is my second last slide, and I just want to give you a feel of where the science is going. So where the science is at the moment, it's moving beyond classical pharmacology. Although drugs are getting smarter, drugs still have side effects, etc. So this paradigm is electroceutics. It's being able to titrate the right amount of inhibition or excitation into the nervous system to modulate the end organ. And this modulation can take place from the central nervous system and the peripheral nervous system at the sensory spinal cord level, or right down at the end organ level where the innervation takes place, or it could take place at the vascular endothelium too. And we have got the technology now to target cell types with site-specific viral vectors. So this is gene therapy that is taking place here. We can make cells from patients and again recapitulate them into the cell type of interest, in this case neurons and heart cells. And we can also autograph and correct the cells in a dish. So this would be like CRISPR that you may have heard about. So you could find the defect, fix the cells, and retransplant the cells back into the tissue again. And for us to be able to do that, we've developed 3D cell structures called organoids and assembloids, as we can take many different anatomical aspects. In this case, the heart, we can put neurons into it, we can put the vascular system into it, we can put the immune system into it to get closer to how we behave in vivo. And then finally, technically, this is where physical sciences meets the biological sciences, and particularly bioengineering with 3D printing, to be able to understand in a dish the actual disease itself and then develop targeted therapies going forward. I'd just like to end on my last slide with a slightly more philosophical slide, and the two clinical students would have seen this because I showed this to them in their first year and second year too, probably at the start of the academic year. So I quite like this quote by Pascal. He's the famous French scientist who the unit of pressure is named after. And this really applies to hopefully what I've just been talking about for the last 40 minutes. I hold it equally impossible to know the parts without knowing the whole, and to know the whole without knowing the parts in detail. So you need to go horizontally, you need to go vertically to get a complete picture about how we work. And at Oxford, we spend a lot of time at this level trying to understand how the system works. We write the textbooks for many of the areas, and the unique selling point about Oxford, I guess, is it's driven by research-led teaching. And we think that's very important. And even though the textbooks that we write, we finish writing them, then they're kind of out of date, and we've got to rewrite them again because science is moving at such a pace. But hopefully you all would have seen a little bit of understanding here and a vignette in my illustration of where the brain meets the heart. So let me stop there, and I'm very happy to take questions if you want to for the next few minutes.
Cool. Thank you so much, Dr. Paterson. That was a really interesting talk. So yeah, thank you very much everybody for paying so much attention and listening to Dr. Paterson's talk. We're going to open up now for a Q&A. Which should be in the kind of equivalent of the chat function of this meeting. So if anyone's got any questions, please feel free to pop them in there, and we'll read them out. And we can have a go through some of those.
There's one in there already. Can you see it?
I was able to just a second ago. Let me pull the Q&A back up. Okay, from Peyton, says, how did you develop the organoids?
Okay, so what we do with the organoids, we use what are known as hydrogels, and we couple the cells together. And so we need to culture the cells over a number of days because they're all at different maturation points. So the heart cells, for example, when we get them to grow, they would typically be about 40 days. And then we embed the neurons into them. And because of the co-culture, then they start to find their axonal projections to their target, which is the synapse to the myocyte. So these are probably not pure organoids. They're more like assembloids to an extent because they don't have the full anatomical structure, but they behave in terms of neural excitation on excitability. And you can read a lot about this. If you just tap in organoids in Wikipedia, it will give you an idea. But we use sort of hydrogels to make this happen.
Perfect, thank you.
I have a question. My question is, why did you choose this line of work? Why did you become a research scientist?
Yeah, that's interesting. Because I didn't start thinking about this, to be honest. Like for me, and I've been in the game quite a long time now, I've always been kind of curious and followed my nose, e.g. where the data took me, because I started my research in chemoreception. I was really interested in the effect of how low oxygen affected body systems, because I used to climb mountains. And then from there, I got more into regulation of cations on the heart with muscle contraction. Then that led me into the nervous system. So for me, it really hasn't been a linear path of discovery. It's been quite non-linear. That is, often in research, you end up posing more questions than you answer, which makes it so exciting as an academic, because you're interested in discovery in terms of truth. And that's kind of what keeps us interested in what we do on a day-to-day basis.
Cool. There was a question from Elena about how long it usually takes to become a surgeon. I think Emma's actually just answered it in the chat. So Emma just said, it depends what kind of surgeon. 2 years general training, and then many years afterwards, usually at least 5. I would add to that, yeah, it very much depends on the type of surgeon you want to be.
Exactly, yeah. And what I would say, a lot of my former medical students have gone on to become surgeons, either cardiothoracic surgeons or neurosurgeons. Often the program at Oxford is 6 years, but in reality, when you come in, we don't really say it's 13 because that's kind of a scary number when you're 18. But in reality, it probably is about 13 years, depending on what you end up doing. But it's just a number. And the key thing is one little step at a time.
Why is calcium so important for heart function? What is it chemically about calcium that makes it so important?
Yeah, it's kind of ubiquitous. Its effect on secretory processes and contractile processes. You probably would have remembered this in your first couple of years as a medical student. It's almost like the third messenger within the system. You know about the first messenger to the G protein, the second messengers, cyclic AMP, cyclic GMP. Then all roads tend to converge on calcium, mainly for exocytosis, secretory processes, and contractile processes. So you could see here that it's a very important intermediary where homeostasis must be maintained. If you lose that homeostasis for calcium, then you change excitability, you change contractile performance on organ function. And the organ that's most exquisitely sensitive to this is the heart, of course. The brain, not so, because the brain is protected by a blood-brain barrier, and these large cations just can't get across. If you didn't have a blood-brain barrier, then you'd have all types of problems. And of course, when patients get neurosurgical trauma or head trauma and disrupt their blood-brain barrier, then they are vulnerable to changes in cations, which can affect neural function.
Perfect, thank you. There are a couple more in here. How do you apply for medical work experience outside of school, and what London hospitals do you recommend?
Well, work experience is really difficult, isn't it? Because often it comes down to opportunity, and not everyone gets the same opportunity. So, like, I've been admitting medical students at Oxford for over 30 years, and I've read thousands of UCAS forms. And, some people might have had the chance to go to Addenbrooke's and see a heart transplant, and, other people at best might get to talk to a GP. It doesn't matter, right? And let me just say that straight up as someone that pushes the button on who gets in and who doesn't get in, because again, it depends on the opportunity. What I would say to prospective students, I would find it odd if you've never talked to a doctor about what is it like to be a doctor, even your own GP, for example, because what we're interested in is what informed you to make this life choice at 18 or 17 at the moment. So, and you'll be pushed on that at interview. How did you get to this position of wanting to be a doctor? Because one of the things that we're trying to do is to establish whether medicine is the right course for you or not. And you're not doing it because your mother wants you to do it or your grandmother wants you to do it. And in reality, you really want to do philosophy and physics. So we need to kind of figure that out. And that's one of the games of the interview. Certainly at my college, we would ask about that. We're kind of interested in your motivation to doing medicine, and any work experience you can bring is great because we're happy to talk about it. But equally, if you haven't had the opportunity to, see a lot of hospital stuff, then that's also fine because it's really hard to be able to do that these days for work experience, given all the safeguarding issues of people.
Perfect. How do you get into the academic/research side of medicine, and do you need to do another degree after studying medicine to get into it?
Yeah, so you've got two routes of entry. You can do medicine and then get pre-qualified, and then you have to do postgraduate research and do a doctorate of philosophy and science, or you could do science from the start in terms of biomedical science and then do a master's degree of science and then a doctorate. So there are two tracks, and often you probably don't want to think too far ahead about this because you need to be informed and have a little bit of knowledge to make those decisions. So typically that's why you need your first degree. And at Oxford, because the medical course is 6 years, in the third year, you get to do what's called a final honours school for a Bachelor of Arts degree. And During that degree, you get exposed to research. And about 5 to 10% of the medical students, and we admit 155 a year, get really into research. And usually they're the students that want to do a higher degree and spend even more time before they qualify. And some may just stay in medical research because they get so excited about it and want to work at the cutting edge in medical science, and that's fine. You know, like we don't try and overprescribe it. The third year, to my mind, is probably the best year because it's the only time in your whole degree you get to decide what you want to do, because otherwise we're telling you what to do in terms of curriculum, but you get to choose. So if you want to do immunology, if you want to do neuroscience, if you want to do cell biology, you can do that. If you want to do genetics, you can do that. And you can go and work with some of the world's leading scientists at Oxford and spend time in their lab. So you get very focused and very subspecialized in the third year, but you choose what you want to do. And that's important because you've got to take ownership of it. You have to live it. The first 2 years, you've got to do everything because it's the same for every British medical student in the UK. So, you know, you've got to do some anatomy, you've got to do some physiology, you've got to do some biochemistry, you've got to do some pathology, etc., etc. At Oxford, because we're a year longer, you get 2 years of physiology because we think that's really important for a basic understanding of pathophysiology for science and treating patients. So we tend to spend a bit more time with the medical student and getting them to understand the cause of disease mechanistically, rather than just be descriptive about it in terms of, well, you see it, therefore you've got to treat it in this way. We don't do that completely. We pick that up, but importantly, we go for mechanistic understanding.
Thank you. Semi-related question. If I were to want to specialize, for example, into genetics or an adjacent specialty, how would I go about that after my undergraduate degree?
Yeah, again, quite easy. Like Oxford is a real hothouse for research, as you know. So, you know, genetics is one of the great strengths of Oxford research-wise, and you can do preclinical genetics work or clinical genetics work. Normally what tends to happen after you've done your first part of your medical degree or your science degree, after 3 years, that's the time you say, well, look, I might want to do some more research. I might want to spend 1 year and do a master's degree, or spend 3 or 4 years and do a doctorate before I go back to clinical school or continue on my science pathway. And normally by that stage, you've got to meet a lot of lecturers that have obviously excited you about the subject area in its own right. And you get a chance to talk to them. You'll get a chance from their lectures. You'll get a chance to hopefully have tutorials with them. And you might get a chance to work in their lab as a project student. And that way you test drive it, both the subject and also the people.
Thank you. You sort of already answered this as well, but what drew you to neurocardiology over other specialisms?
I guess just by chance, like, because I started in respiration, chemoreception. Then I got interested in excitability on the heart, and then I could see that the heart wasn't the answer to itself. It was a more complex organ in terms of communication to the nervous system. And also I'd studied in the United States at postdoctoral level as well. So, you know, I came originally from New Zealand via Australia on a scholarship to Oxford to study. So, and then I went to America to do even more studies. So in some ways, I was a student for almost late 20s until I got a job that could pay the fees. But that's kind of what we did. We weren't too directed. In many ways, this is 30, 40 years ago. It was a lot easier than it is now. The competition, there weren't many of us in the system. So, but there's opportunity, you know, to go anywhere in the world, but basically if you're committed and driven. And one of the things that we're trying to change in Oxford, like when we teach medical students, we tend to teach them in a very organ-based system. So If you want to be a cardiologist, then you study the heart. If you want to be a neurologist, you study the brain. And we tend to bifurcate that, to my mind, quite early in the curriculum, whereas in fact, probably what we should be doing is spending a little bit more time about this interaction, horizontal integration across different organ systems, because they all communicate to one another. And often you might find a cardiac problem, but it's got a neurological origin. And it takes a very special physician to get that diagnosis, because it can be missed by the subspecialty. And so we're trying to rethink some of this training. The Americans are better at this than we are at the leading medical schools, I think. Their curriculum is a little bit more flexible than ours. British medical schools, I'm not British, so I can say this, but British medical schools are fantastic. Like in the top 10 in the world, the UK's got 4 and the rest are American. So this is something we do really well in the United Kingdom, is medical schools. And I just don't mean Oxford and Cambridge. I mean all over the place. So the GMC has got a really good standard in the United Kingdom. So whichever medical school you go to, you'll get a really good education. It's good here. So I just want to reinforce that, because obviously not everyone can get into Oxford. And like we only take 155 students a year, and we have a couple of thousand apply, and we only shortlist for interview about 450 based on, well, it used to be the BMAT. Now it's a different test, like UCAT based test. So it's hard to get in, really hard to get in, but unless you apply, you don't get in type thing. So you have to really consider that. And if you get invited to interview, then your odds ratio is quite good. Like it's like 1 in 3. You know, that's pretty good odds to make an impression to get in. So that's kind of a long-winded answer to, you know, how I got there. And, you know, it's hard to plot people's careers in a linear way. Like, I guess if you talk to any professor at Oxford or head of department, they would have a similar story. Most of them didn't figure out from when they were 17 they were going to be a nephrologist, and when they're 65 they're still a nephrologist. I'd be very surprised if you found someone like that. They've all come from different walks of life and done different things. I think the key thing is to be really excited and passionate about what you do, because you got to live it, and it's not a job. Like being a doctor is not a job. It's a way of life. Okay, and your patients are there 24/7, and doing research is a way of life. It's not 9 to 5. It's not like being a dentist, you know, where every day is a new tooth. It's a different job. Okay, and it's not for everyone. So think carefully before you jump. That's what I would say into the profession. And to my mind, having watched it for decades, one of the qualities that make an outstanding medical student and junior doctor, like you got to be bright. I won't take that away, but the key word for me, it's just one word, is resilience. You got to have resilience to do well, because you have to learn to deal with disappointment. And that's a really important characteristic that we need to instill in our training. And in some ways in the school training too, before you even get to us. You know, you've got to be able to learn to bounce back and deal with disappointment. And it might seem from where I'm standing that, you know, everyone looks at a place like Oxford and everyone's super, super successful. Sure, there are a lot of successful people, but if you talk to them, they don't talk, you know, people don't talk about their failures, right? And there's a lot of that, right? And I think one of the key things which I really like about Oxford, because I've been here a long time now, is that, you know, there's no such thing as criticism with us, only feedback as tutors. And in some ways, we're a little bit like mountain guides. You know, our job is to guide the student and the pupil up the mountain safely. But the mountain ain't changing its altitude, okay? The standard is the standard. and we're really tough on that, because the only thing we discriminate against is poor academic performance. Everything else we kind of don't care about that much, right? We want to get the best out of people. But the standard is the standard. So you get the degree, you've earned it type stuff. And that's why Oxford is Oxford, all right? And we make no apology for that, okay? And I guess the British taxpayer would not want us to do it any other way, since they're paying for it all. So it is tough, and you get challenged, you get pushed, you fall over, you get back up again, and you keep going. But we graduate, some of the best doctors in the world from Oxford that have fantastic careers. So I'd encourage you to apply.